Thank you for allowing us to present this interesting case utilizing the robotic platform to remove a screw following anterior lumbar interbody fusion. We have no disclosures related. Our patient is a 58-year-old otherwise healthy male who had developed significant low back pain as well as bilateral lower extremity neuropathy. He underwent an uneventful L4-S1 anterior lumbar interbody fusion with anterior plate placement via retroperitoneal approach. At the time, to minimize inflammation, he also had placement of a heavy chain hyaluronic pentraxin 3 onlay. Several months later, he developed symptomatic bilateral inguinal hernias and underwent robotic transabdominal preperitoneal repair with mesh. He did have persistent back pain at 1-year follow-up and routine imaging was obtained. His immediate films following his procedure showed good alignment and no issues. However, X-rays 1 year later showed concern for one of the anterior plate fixation screws backing out. This was concerning due to the proximity to the iliac vessels in the sigmoid colon and rectum and the continued movement of the screw. Collaboration with the spine team, the device rep, and general surgery allowed us to put together a plan for removal via the robotic platform and to do so transperitoneal. This would enhance healing time, allow for minimally invasive approach to minimize pain and recovery, and the potential for an outpatient procedure. Likewise, the ability to counterclockwise remove the screw was aided by having the ability to rotate instruments 360 degrees, allowing for full insufflation to be maintained. Backup plans for open surgery were also discussed should the need arise. We began by achieving pneumoperitoneum with OptiView entry into the abdomen and immediately identified the sigmoid rectal junction and the peritoneal entry into the mesorectal plane. The patient was placed in steep Trendelenburg to allow for easy mobility of the small bowel out of the pelvis. Clear identification of the aortic bifurcation is easily noted, and the peritoneum is scored and open below this. With utilization of the heavy chain hyaluronic pentraxin 3 at the initial operation, the degree of inflammation and scarring was noted to be minimal. Anterior retraction of the rectum is performed both robotically and with an assistant throughout the exposure. Dissection down to the sacrum proceeded with control of small vessel bleeding, only requiring cautery to control this. The dissection quickly allowed identification of the proud screw which had backed out. Exposure of surrounding tissue to assure proper visualization was performed. Initially, the ProGrasp driver was used to attempt to back out the screw further, but this did not have the ability to grip the head of the screw properly, and so a combination of the scissors opened in the head to get good traction and rotation of the screw counterclockwise to further back this out was performed. The screw was additionally loosened until complete removal. Bleeding was controlled with only cautery with bone wax on backup if needed to be applied robotically. The screw was then locked into the screwdriver in order to be removed via an 8mm trocar. Finally, the peritoneum was closed in a running manner with a barbed suture. The entire case time was under 45 minutes, and the patient was subsequently discharged home from the recovery room. Follow-up imaging notes all plates in good location as well as the screw removed. Screw loosening following anterior plating of the lumbar spine is an uncommon issue to encounter and can require removal. Use of the Da Vinci allowed us to treat this patient quickly with a minimally invasive approach and quick recovery.
Exciting. Very good.
Thank you.
Thank you.